Yes, sir. 3, 2, 1, start.
A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. So today we have a presentation on renovascular hypertension. So this will be presented by our resident, Dr. NIHAL Singh, and would be moderated by our faculty, Dr. KULDEEP. So I would request NIHAL to kindly share his presentation.
Being respected teachers and everyone. Today's topic of seminar is renovascular hypertension. I'm Dr. Nihal Singh Balawat and moderator is Dr. KULDEEP POONIA. First, we start with the introduction. Renovascular disease. It is a state in which there is a reduced perfusion of the kidney exists with or without hypertension. Ischemic nephropathy defined as the reduced GFR associated with the reduced renal blood flow beyond the level of autoregulatory compensation. And renovascular hypertension is a clinical syndrome marked by a rise in the arterial pressure with or without associated ischemic renal and hypertensive injury. Now, most common reason for the renovascular hypertension is renal artery stenosis. It is defined as the narrowing of the renal artery by more than 50% of its natural diameter. It is the most common form of the secondary hypertension and potentially curable hypertension. Epidemiology. Of all hypertensive patients, 5% patients are of the renovascular hypertension, and of the end-stage renal disease population, 10 to 20% are of the renovascular hypertension. And patients present with the moderate to severe hypertension, that is hypertensive emergency, in malignant hypertension, 10 to 14 patients per patient are of the renovascular hypertension. Now, etiopathogenesis, most common cause of the renovascular hypertension is atherosclerosis, that is 60 to 80%. And second most common cause is the fibromuscular dysplasia, that is 20 to 40%. Atherosclerosis obliterans, it affects male more than female. Common age group is 40 to 70 years of age. As atherosclerosis involves the large to mid-sized vessels, so it is the extension of the plaque from the abdominal aorta to the renal artery. So it involves mostly proximal 1/3 of the renal artery, and in proximal 1/3, a 70 to 80% plaque involve the renal ostium, and 30% are non-ostial narrow. Fibromuscular dysplasia, in contrast to atherosclerosis obliterans, it involves the young Caucasian women. It is bilateral disease, and it involves the distal segment of the renal artery. Types of the fibromuscular dysplasia, that is medial fibroplasia, involves 30% population. Perimedial fibroplasia is 5%, and intimal fibroplasia is the 5%. Medial fibroplasia occurs exclusively in the women between the 25 to 50 year of age. On angiography, it appears as a string of bead appearance. It usually does not progress to the end-stage renal disease because it does not causes the complete occlusion of the renal artery, and it involves the distal most part of the renal artery. So some segmental branches are spared. So medial fibroplasia does not progress to the end-stage renal disease. This is characteristic appearance of the renal angiography, string of bead appearance. Perimedial fibroplasia, it is also called the Gurley's disease because it affects the women of 15 to 30 years of age. It affects only renal artery, and it affects mid part of the renal artery. It also present on renal angiography like string or bead appearance. It affects mid part of the renal artery, so it usually leads to the complete occlusion of the renal artery and may progress to the end-stage renal disease and loss of renal function. Intimal fibroplasia, it predominantly occurs in children and the younger adults, and it results in the perirenal hematoma and dissection and may lead to the rapid onset renal infarction and end-stage renal disease. Now, classification of the renovascular hypertension. There are two types of renovascular hypertension. One is two kidney hypertension and another is the one kidney hypertension. These are the causes of the two kidney hypertension: unilateral fibromuscular dysplasia, unilateral atherosclerosis obliterans, renal artery aneurysm, renal artery embolization, and traumatic occlusion, and arteriovenous fistula and Pey's kidney post-traumatic. One kidney hypertension usually occur in the stenosis to the solitary kidney, bilateral renal artery stenosis, and vasculitis involving the renal arteries. Now, pathophysiology of the renovascular hypertension. Goldblatt was a pathologist. In 1934, he demonstrated that in dogs, if we clip a renal artery, he demonstrated two models. One is 2 kidney 1 clip model and one is 1 kidney 1 clip model. In 2 kidney 1 clip model, he ligated the one renal artery and opposite kidney was normal. In 1 kidney 1 clip model, one kidney was removed and one or solitary kidney's artery was clipped. So in 2 kidney 1 clip model, there is it is renin dependent model, because after ligation of the one artery, there is decreased perfusion to the kidney and leads to the decreased GFR and decreased urinary sodium delivery to the distal convoluted tubule. That leads to the renin activation, angiotensin 2 activation, and but opposite kidney is normal, so there is diuresis and natriuresis from the opposite kidney. So there is no feedback inhibition of the renin in the 2 kidney 1 clip model. So it is a vasoconstrictive model. Because of the no feedback activation of the RAS activation, angiotensin level are increased and it is dependent on the RAS system. In 1 kidney 1 clip model, after ligating the one renal artery, opposite kidney is not there or not functioning. So there is no feedback inhibition of the renin. There is feedback inhibition of the renin. So renin is normal in these cases, and it is a volume dependent model. So in 1 kidney 1 clip model, we use the diuretics to decrease the symptoms of the hypertension. So 1 kidney 1 clip model is a volume hypertensive model. Plasma renin levels are normal. Now, whom we suspect the renovascular hypertension? Usually, these patients present with a severe or refractory hypertension with grade 3 or grade 4 hypertensive retinopathy. There is abrupt onset of the moderate to severe hypertension. Age group that affected are the less than 20 years or more than 40 years without a family history of hypertension. And there is unexplained worsening of the renal function on using AC inhibitors or ARBs into 1 kidney 1 clip model, and to 2 kidney 1 clip model, there is paradoxical worsening of hypertension in use of diuretics. There will be unexplained recurrent episodes of heart failure, that is, patient presents with the recurrent flash pulmonary edema. And on clinical examination, there will be abdominal bruit will be present, that is throughout present in the systole and diastole. And patient will be present with a diffuse vascular disease, and cholesterol embolization will be there. Now, symptoms of the renal hypertension: patient presents with the headache, hypertension at young age, blood pressure that is difficult to control even after 2 to 3 medications, blurry or double vision, and flash pulmonary edema will be there. Now, renal manifestation of the renal vascular disease: renal artery stenosis may be asymptomatic, because if there is no significant narrowing of the renal artery, that is more than 50% occlusion or more than 70 to 80% occlusion of the renal artery. So if it is less than that, patient may be asymptomatic. It may present with the renovascular hypertension. It may present with the ischemic nephropathy, and it may be associated with the accelerated cardiovascular disease. Now, investigations of the renovascular hypertension: there are two types of investigation. One is non-invasive screening investigation, and other is the invasive investigation. Now, historical investigation is the IVU, in which we see that there will be notching of the pelvic ileal system because of the collateral vessels compresses the pelvic ileal system. And in non-invasive investigation, first investigation we do is the magnetic resonance angiography. Its sensitivity is 100% and specificity is 71 to 96%. But the disadvantage of magnetic MRA is that it does not delineate the distal or intrarenal vessels, and accessory renal arteries can be missed. And in case of the chronic kidney disease where GFR is less than 30, gadolinium contrast may lead to the nephrogenic systemic fibrosis. Spiral CT angiography: sensitivity is 98% and specificity is 94%. It is contraindicated. It is limited in renal insufficiency patient, and it is contraindicated for creatinine more than 1.7 milligram per deciliter. No. Screening investigation of choice is the duplex ultrasound, renal ultrasound. We usually it is operator dependent, and we calculate resistive index in the duplex ultrasound. Normal resistive index of the kidney is 0.6. If it is more than 0.7, that signifies that there is a renovascular hypertension, or it is in affected kidney and normal kidney, the difference is more than 0.1. That also suggests there is renovascular hypertension. Also, there is a renal Doppler. We also calculate peak systolic velocity. normal peak systolic velocity of the renal arteries is 60 to 100 centimeter per second. But in case of renal artery stenosis, peak systolic velocity is greater than 100 to 180 to 200 centimeter per second, and the renal artery to aortic artery velocity ratio is more than 3.3 to 3.5. Now, another invasive investigation is the angiography and intra-arterial DSA. It is the gold standard. If it is indicated when there is a high clinical index of suspicion of renovascular hypertension and intervention is contemplated. There are two kinds of angiography we do. One is conventional and another is the intra-arterial DSA. In conventional distal subtraction angiography, the contrast required is more, but complications are less. In intra-arterial DSA, contrast required is less, so we can use it in the renal insufficiency patient, but local complication like renal artery dissection and thrombosis is more. Two historical invasive investigation are also done previously. First is captopril renography. So we give captopril, oral captopril 20 to 50 milligram. Prior to this isotope injection, we do the DMS or MAC3 scan baseline, and after the captopril renography, we again do the MAC3 scan. So captopril is AC inhibitors. So usually, hemodynamics is maintained by the ACEs. By doing the efferent arterial vasoconstriction, GFR is maintained. But after giving the captopril, efferent arterial renal stenosis is lost, so GFR will be reduced after giving the captopril in the renovascular hypertension patient. Another invasive investigation is the renal vein draining measurements. We cannulate the renal vein, both renal veins, and if there is a difference ratio of stenotic kidney to non-stenotic kidney is more than 1.5, that suggests that there is a renovascular hypertension in the 90% of the patient, more than 90% of the patient. Now, management of the renovascular hypertension, there's three kinds of management: medical management, angioplasty with or without stenting, and surgery. Usually 90% of the renovascular patients are managed by the medical management only, mainly on the ACE inhibitors and ARBs. But the disadvantage of the medical management is that the underlying cause is maybe increased over the time, and it may lead to the renovascular insufficiency. And there will be changes in the kidney on biopsy that will suggest the renal tubular atrophy, interstitial fibrosis, or glomerulosclerosis, and progressive loss of renal function will be there. Now, intervention we do is a percutaneous transluminal renal artery angioplasty. One trial was done, Estel trial, that suggests that the best results are in the, if there is less than 10 mm length of the plaque is there, partially occluded renal artery is there, and does not involve the ostium. That gives the better result by the renal percutaneous transluminal renal angioplasty. Before doing the PTRA, we should do the renal biopsy. If renal biopsy suggests there is glomerulosclerosis, tubular atrophy, or interstitial fibrosis, so that kidney is not salvageable, so we should not perform the angioplasty in this kidney. Results are better in the fibromuscular dysplasia, recent onset of the hypertension, poorly controlled hypertension despite medical therapy, and if patient is unable to tolerate the medical therapy. Now, percutaneous transluminal renal angioplasty in unilateral atherosclerotic disease, success rate is low as 70% in these patients because there is elastic recoil in atherosclerotic disease. So we always use the stent in this patient. Improvement of hypertension is 86% of the patient in unilateral osteal disease as compared with the 46% with the osteal lesions. Complication of the PTR is thrombosis, perforation, dissection of the renal arteries, diffuse atheroembolism in 50% of the patient occur. Bilateral, in case of the bilateral atherosclerotic disease, results are disappointing of PTRA, and because these are stenosis are difficult to dilate, there are high complication rate, and these are unsuccessful in the 60% of the patient. Now, in case of the atherosclerotic obliterations, we do angioplasty with stenting, and successful stenting can be achieved in the 100% of the patient. Pre-stenosis rate is 15 to 20%, but there is no statistically significant difference in the BP in the atherosclerotic patient. Now, complications of the PTR or stenting is hematoma formation at the puncture site, renal artery spasm, that may lead to the local thrombosis and renal infarction, reversible acute renal failure, renal artery perforation, occlusion, dissection, and irreversible acute renal failure resulting from the atheroembolization of the thrombus that is less frequent. Now, there are three trials, randomized control trial on the angioplasty done. One is the STAR trial. Patients are randomized to the stenting and medical therapy alone. But this is a negative trial. This shows no difference in the degree of BP control. Another trial is the ASTRAL trial. It is also shows that there is no difference in the BP control between the two groups. And another trial is the CORAL trial that was concluded in 2014. So this trial also concluded the risk of the stenting does not seem worth the potential benefits. Now, in which cases PTRA is, we should do the PTRA. First, we do the biopsy. And if biopsy suggests that there is end-stage renal artery disease, and there is evidence of glomerulosclerosis, tubular atrophy, or interstitial fibrosis, so that kidney is not salvageable. So we should not do renal artery PTRA in these patients. Window of opportunity is defined as if there is serum creatinine between the 1.5 to 3 milligram per deciliter, then we should go for the PTRA. If patients are having hemodynamically significant renal artery stenosis, accelerated hypertension or malignant hypertension, we should go for PTRA. Hypertension present with an solitary functioning kidney, hypertension with intolerance to medications, and if renal stent placement is indicated for osteal lesion that meet the clinical criteria for the intervention. On a Doppler study, if it shows that there is distal runoff and retrograde flow of the arteries is there, then we should go for PTRA. Now, this is the flow chart showing the management of the patient in the atherosclerotic renal artery stenosis. We first attempt the medical therapy. If it is successful, BP control is there with a stable renal function, we should observe the patient. If medical therapy is unsuccessful and uncontrolled hypertension, rapid deterioration of the renal function is there, we should do angiography and PTRA and stenting in atherosclerosis obliterans patient. If it is successful, we should observe the patient, and technically is unsuccessful or not feasible, then we should consider for the surgical intervention in this patient. In patients with the fibromuscular dysplasia, if it does not involve the branch renal artery disease, we should go for PTRA. If it is successful, then we observe patient. And if stenosis involves the branch renal arteries, we should directly go for the surgery. Now, surgical treatment for the renal artery stenosis is indicated when we operate the patient for concomitant aneurysm of the aorta or occlusive aortic disease. If there is macroaneurysm in the renal artery, that may lead to there is a risk of puncture or rupture is high when we do the percutaneous transluminal renal angioplasty. If there is malignant or accelerated hypertension, and if a patient does not respond to the medical therapy, and transluminal angioplasty is technically impossible to accomplish in case of the osteal lesions. Now, criteria for the best outcome of the surgical revascularization is kidney size should be more than 8 centimeter. There should be the retrograde filling of the distal renal artery on ultrasound Doppler by collateral vessels, and there should be good distal runoff. There should be patent distal renal artery, and involved kidney should be viable, that the biopsy should be normal, and there should be minimal glomerulosclerosis and well-preserved tubules on the renal biopsy. Now, types of the renal bypass we do is first is the anatomical bypass, that is aortorenal bypass. It is preferred technique when the abdominal aorta is not diseased or normal. Non-anatomical bypass are done when there is abdominal aorta is diseased. That is, on left side we do splenorenal bypass, on right side we do hepatorenal bypass, or we do iliorenal bypass. If whole of the abdominal aorta is diseased, then we also consider autotransplantation by using the supraceliac or lower thoracic aorta, as these arteries are not involved by the atherosclerotic disease. Thank you.
Thank you, Nihal. So again, a topic which probably is not much talked about, and though you may always get it in the theory paper, long question on renovascular hypertension, right? So Any query from the residents or faculty, I would like to know. And those who have joined us on Zoom, if they want to make any comment, please raise your hand. So I will summarize the whole thing. Though Nihal has told almost everything about renovascular hypertension, we know hypertension is a disease which is very commonly affecting uh, the world population. It's almost, I think, 10 to 15% of the OPD clinic, they have patients with hypertension. So in US alone, 75 million people suffer from hypertension. And throughout the world, the figures are much, much higher. So when we talk about mild to moderate hypertension, it's renovascular hypertension accounts for around 1% of the cases. When we talk about resistant, malignant, acute hypertension, severe hypertension, it accounts for about 10 to 40% of cases. So how do you suspect a case of renovascular hypertension, right? So we know what is renovascular hypertension. We know it's a systemic secondary hypertension, which is due to renal vessel obstruction, renal artery obstruction, which causes rise in blood pressure. So the causes, the commonest cause, as you said, it could be renal artery stenosis due to atherosclerosis in older age group. In younger, particularly female, you may have fibromuscular dysplasia. And sometimes the other causes could be Takayasu's disease or some kind of a vasculitis, arthritis disease, then radiation arthritis, external renal artery compression, coarctation of aorta. So all these are other causes for renovascular hypertension. How do you diagnose or when do you suspect renovascular hypertension? As he said, so this is one of the common cause for secondary hypertension. So whenever you get a person who is not kind of getting controlled by usual medications. Secondly, if they require 2 or 3 medications, or they cannot tolerate the drugs and the blood pressure doesn't get controlled, there's a short duration of acute hypertension or malignant hypertension. Patients who have hypertension, they are put on ACE inhibitors and they suddenly develop azotemia, rise in creatinine, which is more than 30%, right? And females, premenopausal females, 20 to 50 years of age, are developing hypertension. Patients who develop flash pulmonary edema, which is unaccountable. Patients who develop CHF, which is unaccountable. So all these are the kind of things where you may suspect renovascular hypertension. So once you suspect a renovascular hypertension, you do a physical examination. Yes, you might get a bruit at the renal angle or renal artery stenosis. You may get kind of features of pulmonary edema or CHF or edema, all those things. So once you have examined, what are the different tests? We must know the various causes of secondary hypertension. We all know it could be due to pheochromocytoma, it could be Cushing's, it could be aldosteronism, all right? And it could be renovascular hypertension, renal parenchymal hypertension. So whenever there is a case of secondary hypertension, you must rule out all these, right? So first of all, you begin with urine routine microscopic examination to see whether there's proteinuria, hematuria, RBC cast, and all those. So proteinuria will tell you that there is a renal parenchymal disease. RBC cast and hematuria will tell you that there is a glomerulonephritis probably. And then you do your urea, creatinine, renal function tests. You do a metabolic profile. You do serum electrolyte levels, etc. So after doing all these and ruling out, and then you also rule out pheochromocytoma and Cushing syndrome by doing all those tests, right? So once you have ruled out, then we need to know, and then you suspect if there's one of the kidneys is smaller in size on ultrasound, then you may suspect that this could be a renovascular. So once you have done that, the initial diagnostic tests, the most simpler and the cheaper test is the duplex ultrasound sonography. So when you do a duplex ultrasound sonography and you find that there is on one of the renal arteries, you find the peak systolic velocity going above 200 or 300 centimeters per second. So whenever there is stenosis, the velocity increases. So if there is more than 200, 300 centimeters per second, you suspect that it could be a renal artery stenosis. The other important tests are the CT angio or MR angio. Usually, if it is more than 75% of the arteries stenosed, then you would say that this is a significant renal artery stenosis. Or if there is a post-stenotic dilatation with 50% stenosis, then you would suspect that this is a significant renovascular hypertension. The gold standard being arterial angiography, renal angiography, to know exactly the stenosis, right? But the other tests like captopril renography, the PRA, and renal vein renin measurement, these are all not routinely done. They are not done as an initial diagnostic tests. They are done only later to confirm your findings, right? So routinely, you should not do a captopril renography or PRA or renal vein renin measurement. Once you have diagnosed renovascular hypertension, then again, as I said, the management includes first is the medical therapy. If the medical therapy doesn't help, then only we go for surgical management. And the surgical management includes percutaneous angioplasty and surgical therapy in the form of aortorenal bypass or splenorenal, hepatorenal bypass, or even renal transplantation. So I think this was in brief the whole summary of renovascular hypertension. If you have anything, any comment to make, Nachiket, if you want to say anything on renovascular hypertension and our residents, anything you think is missing or you want to make comment? I have a critique of his presentation, but we will do it later. Right. So if nobody has anything, the renovascular hypertension is not a very kind of a favorite topic. So we can go ahead with the MCQs. Go ahead. Okay. So first question, identify the false statement. One kidney, one clip model is volume hypertensive model. Two kidney, one clip model is renin-dependent model. Treatment of choice in one kidney, one clip model is ACE inhibitors. Treatment of choice in two kidney, one clip model is ARBS. C. So treatment of, yes, pardon? C. Treatment of choice in one kidney, one clip model is diuretics. Okay, why? Because there's a volume dependent result. Okay. So treatment of choice is ACE inhibitors is false. One kidney, one clip model is volume dependent hypertensive model. So the choice is diuretics, right? Identify the false statement. MRA delineates lesions. MRA is a magnetic resonance angiography. Delineates lesions involving distal intrarenal arteries. DSA is gold standard for diagnosing renovascular disease. Duplex ultrasound predicts the patients who will have an improvement in their blood pressure. And CTA is contraindicated if creatinine is more than 1.7. So MRA would not delineate the distal intrarenal artery lesions. Any angiography probably doesn't. The CT and MR, so for that you need the gold standard to write. So intrarenal arterial lesion can be missed on MRA, so it is not good investigation for intrarenal arterial lesion. So even CT angio would miss, right, if there is an intrarenal arterial lesion. Identify false statement. String of beads appearance on angiography occurs exclusively in medial fibroplasia. Perimedial fibroplasia is known as Gurley disease. Intimal fibroplasia is associated with dissection. and perimedial fibromalacia progresses to renal occlusion and loss of renal function. A occurs exclusively in medial fibromalacia. So it can occur in perimedial also. But the typical bead appearance is probably very typical of medial fibromalacia. In perimedial, it is usually proximal and, as you said, mid-path. Okay. So a string of beads appearance on angiography occurs exclusively. This is false. It can occur in perimedial fibromalacia also. So the rest of the things were correct. Intimal can cause, and this is the only fibromuscular dysplasia which can result in end-stage renal disease. The intimal fibromalacia. Rest of that is usually doesn't. All right. I think that's it. So perimedial fibromalacia can also lead to loss of renal function. Okay. So usually the medial doesn't. Otherwise, both of them they can. Yes. Renal vein renin ratio has good predictive value in the identify the faults. In those with bilateral disease, MRA gives both anatomical detail and functional significance of renovascular hypertension. Pressure gradient across a renal artery may predict a reduction in blood pressure with revascularization. Renal vein ratio helps to lateralize the diseased kidney. A. Renal vein renin ratio has good predictive value in those with unilateral. Is it? In unilateral disease. In bilateral, you cannot see. Huh? How does MR medial functional significance? So MR is a study which can help to give the functional exactly how that do you know that? Come here. So tell us exactly how MR again gives the functional significance of renal vascular hypertension.
Sir, on MR angiography, there is a latest trial which MR renogram also we do. So on this basis, it gives the functional detail of, sir, whether kidney is functioning or not, sir, on renogram, sir. We plot the curve.
So verbatimly, your answer was there was a trial in which MR angiography gave a good function. So this is not the answer. I mean, you have to give.
So you have to give exactly how. Yes, do you know that? Yes, because MR is being used for functional study also now for kidney function. Yes. So how does it measure the GFR? Yes, it can measure the GFR, but how does it? Do you know the exact mechanism? Okay, I think we will deal it with later. Identify the false statement. PTRA with stenting done for atherosclerotic disease. PTRA is done with stenting for atherosclerotic disease. Yes, PTRA without stenting done for fibromuscular dysplasia. Serum creatinine more than 4 is an absolute indication for revascularization. Surgical interventions indicated if concomitant aneurysmal or occlusive disease is present. See, more than 4 is not an absolute indication. Is a acha. Okay. So more than 4 is a contraindication for revascularization. Okay. So windows of opportunity defined by serum creatinine level of 1.5 to and 3 for most interventions to be successful. Acha, they are not successful if it is done more than 4. Okay. Investigation of choice if there is a high suspicion of renovascular hypertension, MRA, DSA, duplex, CTA. So the initial is which is the simplest and the cheapest is a duplex ultrasound, right? So here you can know the peak systolic velocity and the resistive index. So resistive index is peak systolic minus end diastolic divided by peak systolic. If it is usually more than 0.8, then it gives you an idea that it could be renovascular. Yes. And the velocity is more than 200 to 300 centimeters per second. So answer is DSA. If clinical index of such a high and intervention. So again, if intervention is contemplated, then definitely you should confirm it by DSA. But the initial diagnostic test is duplex. So the question was investigation of choice. if there is a high suspicion. Again, once you have a patient coming to your OPD with a when it gives you a suspicion of hypertension renovascular, the first test is definitely a duplex ultrasound. And once you have diagnosed this and then you are contemplating intervention, then that investigation of choice is DSA. I think it should be a little confusing. Anyway, investigation of choice in azotemia and renovascular hypertension. MRA, DSA, duplex, CTA. Again, it should be duplex. Why not duplex? So when there is azotemia, raised creatinine, so no dye. Usually you would not like to give a dye. So CT is ruled out. DSA also you have to give dye. So it is either MRA. MRA again, gadolinium can cause systemic fibrosis. But again, gadolinium, there are two types of gadolinium now. The newer generation gadolinium, the type 2, they usually do not produce the nephrogenic fibrosis. So, so again, duplex probably would be the choice, right? Right. Thank you. So, thank you, everybody. Anybody has any? No comment, no query. All are well read. Nobody has any question. Nachiket, you want to say? After that. So, okay. Thank you. Thank you, all of you, those who have joined us today, and have a good day. And I wish you a very happy Republic Day belated. Thank you.